Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're taking a scalpel to one of the most fundamental procedures in upper GI reconstruction.
One that's continuously evolving, too.
Exactly. Our mission is laser-focused. We're diving into the optimal configuration for gastrojejunostomy, the GJ, based on the latest comparative data. We want to see how we can translate that surgical efficiency into, superior patient outcomes.
And this is such a critical discussion. For any surgeon dealing with these high-stakes cases, I'm thinking post-pancreatic duodenectomy or complex palliative work. The choice between an anterior versus a posterior GJ is, well, it's arguably the single most important technical decision you make at the end of the case.
It really is. It can determine so much about the immediate recovery, right? Their functional status, and especially that crippling problem of delayed gastric emptying.
Absolutely, DGE.
So we've synthesized a heavy stack of sources for you today. Contemporary clinical trials, major reviews, meta-analyses, all to give you the sharpest, most current clinical update out there.
But technique is paramount.
It is. And before we get into the weeds, we have to start with the mandatory disclaimer. Please remember, this content is for reference only. Please follow local guidelines and protocols in your clinical practice.
Okay, with that crucial point made, let's nail down the basics. The anatomy.
Let's do it.
At its core, a gastrojejunostomy is just creating a direct surgical connection and anastomosis between the stomach and a piece of the proximal jejunum.
So you're bypassing the pylorus and the whole duodenum.
Exactly, the whole pathway. Functionally, we're trying to place that connection somewhere around, say, 20 to 40 centimeters distal to the ligament of Treitz.
And the big debate we're having today, anterior versus posterior, that's just about where on the stomach we make that connection, correct?
It is. It's all about anatomical access. The anterior approach means you bring the jejunal loop up to the front, the ventral gastric wall.
Okay.
The posterior approach, that requires a lot more work. You have to mobilize the stomach much more to get to the back, the dorsal wall. The operational demands are really different.
And as we're about to find out, the physiological consequences are even more different.
Hugely.
So before we jump into that technical battleground, let's talk about why the GJ is so vital today. I mean, it's the cornerstone of post-Whipple reconstruction, but what else is driving the volume?
Well, reconstruction after PD is a huge pillar, you're right. But the single largest contemporary indication today is actually palliative care.
For malignant gastric outlet obstruction.
GEO. Exactly. You see it with unresectable pancreatic cancer, distal gastric tumors, sometimes advanced duodenal or biliary cancers causing that, external compression.
And this is where the surgical GJ really goes head-to-head with endoscopic stenting. The literature seems pretty clear on this one, doesn't it?
It really does. Look, a stent is fast, it's minimally invasive, gives you quick symptom relief, but the patency just isn't durable.
So it's a short-term fix.
It's a great short-term fix. But the evidence consistently shows a surgical GJ offers much longer sustained patency, fewer reinterventions down the road. So if your patient has an estimated life expectancy of, say, more than 2 months,
the surgical red is the better option.
It's the more durable solution for symptom relief, for nutrition, and, for your overall quality of life.
Right. So it's a more robust procedure, assuming the patient can handle the operative stress. Are there any other indications we should mention?
You see it less often now, but it's still used for refractory benign peptic ulcer disease, the kind that causes a bad pyloric stenosis.
Okay.
And sometimes for transgastric jejunal feeding access. But really the core of this debate, the thing that's driving all this refinement of technique, is that post-PD setting, where DGE rates can just be astronomical.
Let's get into it then. The technical decision. Starting with the anterior approach.
Yeah.
Why is it still so popular, especially if we know there are DGE risks?
The appeal is, well, it's pure quantifiable operative efficiency.
It's just faster.
It's just faster. The anterior technique, you bring the jejunal loop up, usually in front of the colon anastomosis, and you anastomose it vertically along the greater curve of that front wall.
And what's the big operational benefit there? What does the literature say?
It's all about technical simplicity. You get to avoid 2 pretty time-consuming steps.
Which are?
First, you don't have to do a full mobilization of the back of the stomach. And second, depending on the route, you don't have to create a window through the transverse mesocolon, which can be thick or, really fibrotic.
So in a patient with a lot of adhesions from prior surgery, it's just a more direct path.
It's a much more straightforward corridor, less dissection time.
And that time saving, it's not trivial. We're talking about something like 30 to 40 minutes of total operative time.
That's right. And those minutes are absolutely critical when you're dealing with a patient who has limited physiologic reserve. Someone frail, a complex re-up,
Or even a septic patient.
or a septic patient where you need rapid source control. In those cases, the shorter, simpler anterior approach is often the pragmatic, life-saving choice.
Okay, but here's the tension. That 30 minutes you save in the OR can lead to a much longer recovery, specifically because of delayed gastric emptying. So why is the anterior approach so predisposed to higher DGE rates? What's the physiology?
The thinking is that it's all about poor biomechanical alignment.
Okay.
When you attach that jejunum to the anterior wall, the path for gastric contents is sort of up and then sharply forward, and that just runs counter to all the natural forces at play.
So it's not a simple mechanical blockage. It's actually fighting the body's own motor patterns.
Precisely. The anastomosis can be perfectly wide, totally patent, but the geometry just doesn't line up with the vectors of gastric peristalsis. The antral contractions, they want to push everything down and toward the back wall. Manometry studies suggest that with an anterior GJ, the stomach just has to work harder against gravity and its own motor axis to get food out. And that suboptimal geometry, that's what contributes to the functional stasis, to DGE.
Wow. So that's a stark trade-off. 30 minutes in the OR might cost the patient days of having an NG tube, a longer hospital stay. A real struggle with nutrition.
It can, yes.
All right, let's flip that. Let's look at the evidence shift that is strongly favoring the posterior approach now, especially after a PV.
The posterior approach is, well, it's more meticulous. It requires a wide mobilization of the stomach to get to that dorsal wall. You often have to carefully divide the short gastrics.
The more involved.
Much more involved. But the recent prospective comparative series have shown that the extra effort pays off.
Yeah.
Immense dividends.
What are the key findings from those studies? What really solidified this preference?
It's the magnitude of the DGE reduction. That's the key. Specific data, particularly from high-volume centers in Asia, have shown a substantial drop in clinically significant DGE rates.
That's substantial.
We're talking from maybe the 20 to 25% range down to below 10%, just by using a posterior vertical GJ. And these are hard endpoints. Earlier NG tube removal, quicker return to a solid diet, shorter length of stay. The difference is big enough to change practice.
So what's the physiological reason it works so much better? You said the anterior wall fights the natural vectors. How does the posterior one optimize the flow?
It creates a true gravitationally and peristaltically favorable path, a better trajectory.
Like a downhill slope.
It's almost exactly like a smooth downhill chute. By putting the connection on that dorsal wall, you're creating a more direct line of exit that aligns perfectly with gravity when the patient's upright, and more importantly, with the sweeping action of those antral contractions.
The path of least resistance.
It is absolutely the path of least resistance. And there might be another subtle factor here, vagal nerve preservation.
Oh, that's interesting.
It's hard to quantify, but some theories suggest that the careful dissection you have to do to mobilize that posterior wall might lead to better preservation of the posterior vagal trunk and its connections, and that could independently improve motility.
Fascinating. So it's not just simple geometry. Okay, so we've got posterior winning on physiology and DGE, while anterior wins on speed. But it's not just about the attachment point, is it? We also have to think about the route of the jejunal loop.
Correct. The route. Antecolic versus retrocolic.
And the evidence here seems a lot less controversial. The antecolic route, bringing the jejunum anterior to the transverse colon, that's the overwhelming favorite for reducing DGE, right?
Overwhelming is an understatement. The antecolic route is just. It's simpler, it's faster, and it's functionally superior in the vast majority of cases. Doesn't matter if you choose an anterior or posterior gastric attachment.
I've seen some series report a massive difference.
Some have shown a tenfold difference in DGE rates favoring antecolic. It's really become the default choice for elective cases.
So why would anyone ever choose the retrocolic approach, passing the jejunum behind the colon, if the functional data is so poor?
It really serves as a bailout. It's the route you have to take for patients with, say, extensive upper abdominal adhesions where the antecolic space is just obliterated.
Okay, so a technical necessity.
A technical necessity. And you also see it historically in some bariatric series where they favored it, thinking it might lower stricture rates. But for oncology reconstruction, antecolic is the functional gold standard, no question.
Let's talk about the anastomosis itself. Site-aside versus end-aside. what does current best practice say?
The practice here is pretty unequivocal. We strongly advocate for a wide patent side-to-side anastomosis.
Over anticide.
Absolutely. And that applies whether you're using staples or hand sewing the connection.
What's the core mechanical advantage? Why is it so much better?
It's just the sheer size of the opening you create. A side-to-side gives you a much larger diameter connection, which significantly cuts down the risk of long-term stricture.
Makes sense.
And it also allows the jejunal loop to lie flush against the stomach wall, so you get less tension, less risk of kinking or compression. Long-term patency is really all about the width of that opening.
Okay. We've spent a lot of time on DGE, which is obviously crucial. But let's quickly review the other major complications. We have to remember the risks we're trying to mitigate here.
Of course. While DGE is the most technique sensitive, ranging from, 10 to 40%, the one we all fear is an anastomotic leak.
Which runs at about, what, 2 to 5%?
Around 2 to 5%, yes. And that's a direct measure of our technical diligence. Is the anastomosis tension-free, well-vascularized, meticulously constructed?
What about stenosis or stricture? Does side-to-side get rid of that risk?
It minimizes it, but it doesn't eliminate it. You still see stenosis in about 3 to 6% of cases. The good news is those are usually manageable with endoscopic dilation.
Right.
But we should also mention the risks tied to the different routes.
It's like internal hernia risk.
Exactly. An internal hernia is a unique and often delayed complication tied almost exclusively to that anecolic route. If you leave the mesenteric defect open.
The one you created by routing the jejunum.
Right. If that's left open, the risk of small bowel herniating through it can be substantial, 1 to 10% in some series. So closing that defect, usually with a non-absorbable suture, is a mandatory part of the technique.
Okay, so this brings us back to the table. We've weighed efficiency against physiology, simplicity against stricture. What's the clear, synthesized recommendation for a surgeon doing a complex elective reconstruction today?
The clinical takeaway is pretty robust. The evidence suggests that the configuration that offers the best outcomes, especially after a pancreatic choduodenectomy, is a posterior vertical gastrojejunostomy, using an anecolic route with a wide side-to-side anastomosis.
And that combination gives you the best shot at a good recovery with minimal DGE.
That's right.
But let's circle back to the anterior approach one last time. We can't just dismiss 30 minutes of saved OR time. Where does that efficiency argument still win?
It wins in that patient-centered trade-off. The anterior approach is still the standard choice for non-oncology things like benign peptic ulcer disease.
Okay.
But more importantly, it's the right choice when technical simplicity is the absolute priority. If you're operating on a critically ill patient, an elderly patient, someone severely coagulopathic in an emergency,
You take the time savings.
you take the time savings. You sacrifice the ideal DGE profile to reduce blood loss risk and time under anesthesia. That's the responsible clinical decision. You have to tailor the technique to the patient.
And that's the ultimate goal, isn't it? Understanding the data well enough to make a safe, tailored decision for the person on the table.
Exactly. We're moving beyond just ensuring patency. We're trying to ensure optimal functional recovery.
This has been an incredibly detailed look. Before we wrap up, I want to leave you with one final thought, a provocative one, based on the tension we've explored.
Go for it.
Given the established physiological benefit of that posterior vertical anecolic approach, the better DGE profile, how might that evidence influence your decision when you're facing a really technically challenging abdomen, where you know the anterior approach will save you that 30 to 40 minutes? It's that classic balancing act, long-term outcome versus immediate surgical risk.
And just remember, the success of either path relies on that meticulous technique we talked about. A wide, tension-free, well-vascularized anastomosis. That principle is just non-negotiable.
Absolutely. Well, thank you for joining us for this deep dive into optimizing upper GI reconstruction. If you found this content useful, please do not forget to share it with at least one of your colleagues or friends and spread the word. And also be sure to check out our YouTube channel and other social media pages for more in-depth content.
Until next time.
Safe surgery.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.